As a young doctor, for me, referral process was one doctor referring to the other. But as I gained experience, the referral is a lot more than that. We need to make sure that referral is addressed at every step of the way. I don't think that digital is going to solve it all, but I think digital would be very good tool and very good platform to simplify it.
Hi, and welcome to the fourth episode of Health Access Now, where we explore innovative solutions to address access to healthcare barriers. In the previous three episodes, we spoke to Dr. Saba, CEO of Axios, about his journey, the evolution of access to healthcare, and his dealings during the HIV and AIDS epidemic. Dr. Saba is here with me again, and today we are going to tackle the issue of the referral process. There are many reasons why a patient might be referred to specialty care, including diagnosis, disease management, and treatment beyond the scope of a primary care physician. That's where referral pathways must be clear, timely, and seamless for the patient. In this next episode, we will discuss how access solutions can help smoothen out the referral pathways and help patients overcome some of the most significant barriers. I will start by welcoming Dr. Saba to the conversation, and we can start unraveling this important topic. Hi, Doctor, and welcome back to the fourth episode of Health Access Now. Thank you again for sharing your time with us today. Today, we're going to talk about some of the big gaps in taking care of patients outside of a hospital. We're going to start talking about the referral process. So, I guess we'll start at the very beginning. And can you explain to our reviewers what the referral process in healthcare is?
Yes, I mean, again, as a young doctor, for me, referral process was one doctor referring to the other. But as I gained experience and I worked in multiple constituency and multiple countries, referral is a lot more than that. It's not only referring from one doctor to the other, it's also before referring patient to the right doctor, and even the patient before the patient sees the doctor. So there are issues related to diagnosis, and there are issues related to treatment and then to the follow-up of treatment. So it's a long process, and we need to make sure that referral is addressed at every step of the way. Again, when you study medicine, people say this is the disease and these are the symptoms. But later on in the training, we do learn how to identify from symptoms the disease, because that's the way it works. So when a patient feels pain or feels a lump in the breast, for example, they do suspect breast cancer, but then who should they go to? What are they supposed to do? What kind of tests are needed? Sometimes they don't know, and they could spend months trying to find. Of course, breast cancer is easy in many countries, but not in all countries actually. But it could be you feel pain in the back. So what do you do? Where do you go? And how can we shorten that period to get to the diagnosis? And when we get to the diagnosis, then who should you go to get the appropriate treatment, the appropriate follow-up? So that's how we see the referral process is going from the time the patient feels something that may require medical attention to the time actually they are followed with the treatment. So that's how we see it.
Can you tell me what some of the big issues that patients are facing specifically in emerging markets?
Well, I mean, the issue is that who do you ask to get this diagnosis? Also, I mean, you could go to the physician, but again, I mean, there aren't many physicians. And just to give you some examples, the average in OECD countries is 3.4 physicians per thousand inhabitant. You know, when you go to Mexico, for example, it's 2.4. When you go to India, it's 1.3. So it's one third. In Africa, is like 0.2
Wow.
doctors per thousand inhabitant. So in many emerging markets, doctors are just overwhelmed, and they need to take care of the actually sick people. So there needs to be mechanism to help the doctors uh,
Mhm.
do this kind of referral.
Yeah, we spoke recently an advocacy group for a rare disease, and she was a mom taking care of a rare disease patient, and she was living
Yes.
in a rural area, and she said even to get to the urban areas, she might not have had the correct transport, or traveling with a child who's unwell is so difficult, right? Even if you have the right person to go to, logistically it can be a challenge.
Yes, absolutely. Already, and if you know, and but if you don't know, it's even worse.
Yeah. So do you think it's a bigger problem now in comparison to what it was when you started your career?
I don't think so. I think it's the same. I don't think it has evolved a lot. We have a lot more diagnostic tools, but also we have Google search, and I have many of my friends who come and say, I feel I have a back pain, and I read, and that could be cancer of the bone, and say, wait a second, you have a back pain. There are a million reasons why you may have back pain that this could
Yeah.
not be cancer of the bone.
Dr. Google can be dangerous.
Yeah, and so it complicates actually referral, because that's what it is. You need to have more expertise, but overall, no, because we haven't worked much in this space. Now there are campaigns, as I said. I mentioned, breast cancer, prostate cancer. There are, of course, diseases for which we have improved considerably the referral, because also it improves the outcome. If people are detected early, then they could be cured better. So in these diseases we have made some progress, but I cannot say that in the referral in general we made progress. There is more work to do outside the hospital there.
Okay. And do you think COVID has highlighted the gaps, or do you think it has had any impact?
Well, it is linked to the same thing. Is like identifying the patients and working mechanism for the patients to come. It does. It is still part of the same issue.
Yeah. And so, I mean, if we look towards other industries, the uptake of digital is much faster, I think, than you see in healthcare in general. But do you think the digital revolution can help in this area within the referral pathways?
Oh, definitely. I mean, there are many ways. First is basically funneling a little bit the patient or the knowledge for people to know where to go, identifying, maybe algorithm that could help advise patients uh, before they could see human being. I don't think that digital is going to solve it all, but I think digital would be very good tool and very good platform to simplify it. Now, we have done programs where we have call centers. People, if they feel certain symptoms, well, they call, and then we can help them, like direct them to whoever they should see and take it from there. So there are ways, and it's probably combination between like digital and human contact.
So, what are the biggest obstacles patients are facing throughout the referral process, specifically in emerging markets?
Well, I mean, there are many aspects. As I said, first now Google search is an issue because you have so many diseases that people are a little lost. I can give you an example of breast cancer in Africa. I was saying earlier, breast cancer is relatively easy because you have a lump in the breast and you go to the doctor. But it wasn't as easy because people had beliefs. They didn't know who to go. They went to traditional healers. And most women were coming at stage 3 or 4, meaning
Wow.
inoperable, like lost. To improve that, what we tried to do, we worked with patient association and we worked with the regional hospitals, and we gave them a phone number and say, if the women contact you, or you find women who have a lump, contact this number. And that was enough for them to be helped throughout the way. And we shortened significantly the duration. They were spending maybe 8 months a year in average to actually get diagnosed, and that was shortened to 2 to 3 months, which improved dramatically the outcome overall. So these are like simple aspects, but there are many aspects related to beliefs, to what I would say the neighbor would say, or the cousin would say, and sometimes just neglect is there, too busy. Well, yeah, I'm feeling something. I'll take care a little later. So if there is a way that simplifies that contact with the healthcare professionals or with the healthcare system, then it will go much faster.
Yeah, literally saving lives, I think, because isn't breast cancer one of the cancers that's actually quite curable if you catch it on time, right?
Absolutely, absolutely, and the earlier the better. So everything is done for women to come early, and and that's one of the, I would say, success stories. There is still more work to be done for breast cancer, but there are diseases that, like, if you have an abdominal pain, what do you do? There are a million diagnoses. So how do you go about it, and how does it work? So there are a number of areas that are still very difficult, and sometimes the patients spend months before they get properly diagnosed.
So, what referral mechanisms can be implemented to help smoothen that out? I mean, we spoke a little bit about breast cancer there, but is there anything else you can do?
Yeah, I think as I said, in the beginning, related to referring patients to the right doctor and getting treatment, but there is also referring to the right specialist, following the patient. There is a lot of work to be done, and this work needs to be, it's multisectoral. Again, I mean, sometimes it is sensitizing a physiotherapist, sometimes is sensitizing GPs, sometimes the nurses. So it depends on. It's not only related to the doctor and having a call center. It has to be, again, a multi-sectoral collaboration. There needs to be campaign. If we have patient associations and peer education, it helps a lot. We did that even in the HIV area when I was practicing at the time, because we were overloaded in the hospital with AIDS patients, and the generalists didn't want to deal with AIDS patients because they didn't know how to handle the disease. Not because they didn't want to, it's just they didn't know how to handle the disease. So we made the effort to work with all the general practitioners in terms of telling them how to handle the disease, where they could follow the patients, and we could see the patient maybe once every 3 months or once every 6 months, instead of having to see the patient once a month. And that reduced significantly the workload on us by just working collaboratively and making sure that there is a communication about the patient between us and between the general practitioners. So that's just one example, but we did that with the physiotherapist, we did that with the social workers. So there are multiple aspects. It depends on the disease area, of course, but it's clearly multi-sectoral collaboration that needs to happen outside the hospital.
I suppose with digital now, in terms of having an integrator, you talk a lot about collaboration and communication, but digital really, I suppose, helps that, right? Because you can have
Of
a
course.
proper,
Of course.
like,
And
integrated
at the
care
time we
network.
didn't have that. So we were
Yeah.
calling and sending letters, and
Mhm.
but the reality is that, yes, the digital will make our life much easier in doing this.
So, I mean, the benefits to the patients are obvious because there's going to be better medical outcomes, a more streamlined, I suppose, patient experience in general. But what are the benefits to the system?
And the benefits to the system are obvious. Patients spend less time in getting diagnosed. They get better diagnosis in a way that we don't have to do tests that maybe were not necessary. So it's cost saving. We can detect the disease earlier and treat them more effectively. So there is a benefit for the healthcare system. There is obviously a benefit for the patient as well.
Okay. So, how can governments and big pharma companies help addressing some of these issues?
I think, well, it started with the treatment and improved. In fact, the pharma companies could say, "Well, I I'm responsible for the treatment. I'm not responsible for the diagnosis." Yeah, but if the patient is not diagnosed, they are not going to get the treatment. So the way it started is, as we did these access programs related to affordability or adherence, and we started with the patients who were diagnosed and needed treatment, and of course, we worked on this treatment program. But then when we addressed the issues related to the patient, and you look at the epidemiology, say, well, yeah, but I'm reaching here maybe 50% of the patients. Where is the other half? And that's where you start going and finding that, wow, they are taking too long to get diagnosed. They are sometimes we don't know where they are. So how do we reach out to them? And that's how, even in this program, we moved to what we called access to diagnosis. Now we have to be very careful, and it's heavily regulated area. So we need to make sure that we're not inducing treatment by trying to help in diagnosis, but at the same time, we need to make sure that the patient are diagnosed, even if in the end the doctor doesn't prescribe the treatment of the specific pharmaceutical company. So we have to be very careful about that. But in the end, yes, I mean, we need to find where are the other patients and see if we can help them get treatment, any treatment, not necessarily the treatment of the pharma.
So that's really interesting. And it's my last question today. But so is that kind of how this developed? Would patients come on these programs, and then you'd start speaking to them, and you'd understand that okay, they were a year being diagnosis, or a year and a half, or they had 2 or 3 inaccurate diagnoses before finding the right solution. And then we start thinking, okay, how else can we help? We look for more patients, we find accurate diagnosis. Is that how this, I suppose, the program evolved?
Yes, exactly. And then because you understand their journey,
Yeah.
and we did publish some studies and articles related to that. Once you understand the journey, you start addressing the bottlenecks in this journey.
Yeah.
And that's how you could say, okay, well, if the issue is diagnosis, then can we make the diagnosis easier? Meaning the test, sometimes, it could be lab test or an X-ray. If it's not the lab test, if it is related to the symptom, then let's increase the awareness related to the symptom. If people get the test, but they don't know where the specialist is, then we address that. So you need to understand what are the obstacles and bottleneck that are blocking the patients, and you just address them one by one.
Yeah, because it's something. I mean, I didn't understand fully until I started working at Axios. But you talk about it all the time. How important it is to take care of patients outside of a hospital. Because a doctor probably only has, as you said earlier on, when you were treating AIDS patients, you don't have that much time with the patient, right? So for them to tell you all of the problems that they've faced, or any of the issues they've had in the previous 3 months, it probably wouldn't happen, and the information, I don't know if it would be used then. So to have somebody like us that are actually directly helping the patients when they leave the hospital, understanding where those barriers are, and then trying to help them overcome them, it's so important.
But even if they tell me as a physician, what can I do about it? I will move to the next patient in 5 minutes. So I mean, if there isn't a mechanism to address that at systemic level, they will tell me. I would know what to do, but I can't do it because I'm alone and I am busy with my patients. So what I'm trying to say is that it's just a different mandate, but that could happen, and should happen in collaboration with the physicians, of course, because they do know where the obstacles are. They just need a mechanism to address it.
Yeah. It's so interesting, I speak to patients a little bit through my work, and I really see the impact that we're having. So I'm so grateful to be part of that. But as I say, that was the last question, so that's brought us to the end of episode 4. Doctor, thank you so much for your time today.
Thank you. Thank you very much, Emma. Thank you.
Thank you again, Dr. Saba, and a big thank you to our viewers and listeners who are supporting us on our mission. If you have a question you would like me to ask Dr. Saba, feel free to write to us, and I will be sure to pass it on to him. In the next episode of Health Access Now, we are going to explore adherence in healthcare. So do stay with us, subscribe to our channel, and follow us on our journey into the world of health access to healthcare. Until next time, thank you so much.